Good day, everybody. This is Chris with The Ancient Scholar. I hope this video finds you all doing well. Today I'm going to cover a slightly different topic from the typical ECG content that I've been working my way through over the last few months. And that is because it is becoming increasingly more relevant. And it is actually a topic that I've formally integrated into the pharmacology and toxicology sections of the curricula that I teach as it relates to the paramedic program here at the college. And we have now in the state of New Mexico seen several incidents of this, and it is anticipated that it's going to become more likely to be encountered, and it is proliferating really across the entire nation. And this is the adulteration of illicit opioids by a substance known as xylazine. And I'm going to talk a little bit about what xylazine is, the history, and kind of what's going on with it. So xylazine is actually a very novel agent as far as human consumption is concerned. Xylazine was originally developed in the early 1960s. I believe it was originally developed as a kind of antihypertensive medication. And as we'll talk about, xylazine is essentially, it's a chemical analog to a commonly used antihypertensive agent known as clonidine or catapress. And so they are chemically very, very similar. They're just analogs. They're isomers of sorts. They're very chemically similar, the two molecules, and so they have a very similar mechanism of action. However, there were lots of side effects with xylazine, and so it really wasn't developed for, or it didn't end up being used for humans, but it is a relatively common veterinary anesthetic agent used, I believe, primarily for large animals. And the way that xylazine works, its basic mechanism of action is that it is an agonist of alpha-2 receptors, which is kind of odd if you think about it. When we typically think of medications that cause altered mental status and depression of the central nervous system specifically, we generally don't think of medications that agonize or activate sympathetic receptors. But that's because we typically think of alpha-1, beta-1, beta-2 receptors, right? And when those are agonized or activated, they tend to cause an increase in heart rate, increase in blood pressure, anxiety, jitteriness, vasoconstriction, bronchodilation, those kind of classic or quintessential sympathetic side effects. However, alpha-2 receptors are a little different. Alpha-2 receptors, particularly alpha-2 receptors in the brain, actually feed back. And so what happens is when a neuron depolarizes and it releases catecholamine, neurotransmitters like epinephrine, norepinephrine, dopamine, onto alpha receptors, right? So a neuron fires, and then that action potential reaches the axon. It causes neurotransmitter to be released in the synapse, and then the neurotransmitter activates alpha-2 receptors on the postsynaptic neuron. When those alpha-2 receptors get activated, what they do is they send information that feeds back to that neuron that had fired. And essentially when an alpha-2 receptor is activated, it feeds back and says, hey, you have already fired, you don't need to fire again. And so alpha-2 agonism through fairly complex intracellular mechanisms feeds back to prior neurons and telling them, hey, you don't need to fire anymore. So in essence, it suppresses those neurons. And so when you expose somebody to a substance like xylazine that activates those alpha-2 receptors through that feedback mechanism, you actually get a profound, or you can get a profound central nervous system depression. So that's a basic mechanism of action. And we see that with drugs like clonidine, where if you take a lot of clonidine, it can cause central nervous system depression. And of course, it can cause vasodilation, and it can cause a decrease in blood pressure, which is one of the uses for clonidine. Clonidine can be used for other reasons as well, but that is one of the major indications. So that's kind of xylazine. That's the basic history of xylazine. It was developed in the early 60s, and by the 1970s, we realized this is not really something that's going to be a good medication to use in human beings, and so it was never used for humans, never received FDA approval for human use, at least as far as I'm aware of. But is a very common veterinary tranquilizer anesthetic, and it's not scheduled, right? So it's not considered illegal because nobody's really been using it. And then around the early to mid 2000s, so 2004 to 2006, 2007, right in there, we started seeing adulterated heroin and fentanyl coming out of Southeast Asia, where xylazine was an adulterant, so it was mixed in with the fentanyl, and it was causing a very potent overdoses, and overdoses that you couldn't easily reverse with something like naloxone. Naloxone is a great reversal agent in terms of reversing the effects of opioids, but xylazine does not agonize opioid receptors. It's alpha-2 agonism, and so it's not like there is any antagonist or any reversal or any antidotal agent that we can use for xylazine. And so now we have people where, yeah, we can deal with the opioid, but we can't deal with the xylazine. And that hit the East Coast of the United States in the late 2000s, so 2007, 8, 9, right in there, kind of hit the East Coast, and that's where we started seeing the first cases of the xylazine adulterated opioids causing problems, and since then it has really proliferated throughout the United States, and I believe in pretty much every state we are now seeing a xylazine adulteration becoming a problem, and it may be the dominant adulterant that we see in the illicit fentanyl and fentanyl analogs that people are using. Okay. So that is xylazine in a nutshell. This is what xylazine looks like. This is its chemical structure. So you've got this benzene ring here and these two methyl groups coming off of that. You've got an amine group here, and it is attached to this ring up here on the top. And you can see that you've got a nitrogen and a sulfur here. And overall, one thing I want you to kind of take away from this is because you have a lot of this pi resonance here, electron resonance, you have these methyl groups, this is a highly lipophilic molecule. And so when you inject it, it tends to pass through cell membranes very easily, and it tends to accumulate in fatty areas of the body like the brain. So this is a very lipophilic. It goes into the brain, can accumulate in the brain in high concentrations, and it can agonize the alpha-2 receptors. It attaches and activates the alpha-2 receptors. So that is kind of the basic chemical structure of it. So as far as the pharmacokinetics, we don't have a whole lot of robust pharmacokinetic data in humans because it was never even approved for human use, but we do have some pharmacokinetic data from mainly large animals, so horses, cattle, sheep, and I even think there's some dog data out there. And it varies quite a bit. In certain animals, the half-life is pretty short. It's like, 5-6 minute half-life in dogs and sheep. In other animals, the half-life is a little longer. For like cattle, for example, I think it's a little longer. But the peak plasma concentration is, within 10-12 minutes, right in there. Pretty reasonable bioavailability, but again, humans, we're injecting it, so it has an incredibly rapid absorption. It gets distributed to the fatty tissues via the bloodstream. And yeah, as far as the metabolism goes, it is metabolized by at least phase 1 metabolism by CYP, the cytochrome P450 enzymes, and there are, I don't know, a dozen or more metabolites that are produced, some active, some inactive. As far as like humans, again, we don't have like a great pharmacokinetic data as far as I'm aware of, but it's kind of the standard thing that you would see with most drugs. You have a hepatic metabolism and urinary elimination. Around 70% or so is eliminated in the urine, and again is heavily metabolized by cytochrome P450 enzymes. And through phase one, it's mainly phase one metabolism, and then the metabolites tend to be eliminated in the urine. That's kind of the big picture. So what are we seeing with the major side effects in people that are, injecting fentanyl analogs, heroin possibly, but, fentanyl is a predominant opioid that we're running into these days, fentanyl and its analogs. So xylazine overdose can vary quite a bit in people, but it's pretty potent, and it has been associated with lots of different fatalities. The biggest side effects that we see are going to be, just think of a clonidine overdose. So you're going to have bradycardia, respiratory depression, and hypotension. Now, initially, early on, you actually may see some hypertension early on in the overdose because you do get some alpha-1 stimulation in addition to the alpha-2 stimulation. The alpha-1 effects of the xylazine can cause some vasoconstriction. So you might get like a transitory increase in the blood pressure, but then overall what happens is as you progress through the overdose, you're getting profound depression of the central nervous system and the sympathetic nervous system in general due to the alpha-2 agonistic effects. So yeah, you're gonna get bradycardia, respiratory depression, hypotension are kind of the three big things that you end up seeing. As I understand, you can have an even further substantial decrease in heart rate due to some of the cholinergic side effects that can happen. And so you can actually have additional bradycardia that develops as well, on top of just the bradycardia that you'd see with the alpha-2 effects. There's a lot of chronic things that can happen. And so in people that are maybe not overdosing but are chronically being exposed to xylazine, it can increase the risk for things like hyperglycemia and diabetes, and actually monitoring blood sugar is going to be an important component of the initial and ongoing management of a xylazine overdose. There are lots of kind of chronic central nervous system things that can happen with altered reflexes, dysarthrias involving the cranial nerves. In some cases, in many cases, we're actually seeing necrosis of the skin. So you're actually developing abscesses, skin ulceration, and necrosis. And we think what's happening there is when you take the xylazine, you kind of get this hypertension, and you get this hypotension, and then this bradycardia, and low oxygen, through the respiratory depression, and essentially this kind of vicious cycle of things can shunt blood away from and to the skin, and so you're kind of having these episodes of ischemia to the skin, and over time that ischemia is leading to injury and necrosis of the skin, and then you start developing ulcerations. In the long term, amputations may need to be performed. So that's more of a chronic manifestation. As far as the acute situation, acute overdose is as what you might expect. These people can be profoundly depressed with their mental status. They can be bradycardic, they can be hypotensive, and they may have blood sugar alterations. So those are kind of the things we see in more of an acute overdose situation. As far as the management of a xylazine overdose or suspected xylazine overdose, it's going to be pretty much supportive care. Again, we don't have great antidotal agents. I'm not aware of any research on dialysis, but I would presume because this is so lipophilic, dialysis is probably not going to be a great option for something like xylazine. That's just that's just how I would gestalt it. But again, there may be some evidence that I'm not aware of out there. And so it's really going to come down to really good supportive care. These patients often need to be intubated because they're not able to protect their airway. They're not breathing adequately. They're going to be intubated, placed on a ventilator. We're going to need to support their hemodynamics, fluid boluses, and probably looking at some pathomimetic agents like push-dose pressors, epinephrine, norepinephrine infusions, things of that nature might come into play. You might even initially give some atropine to combat the bradycardic side effects that we can see with xylazine. And then we're just going to kind of have to support the body as best we can and just allow the liver to really burn through that, and then the kidneys to begin eliminating xylazine and its various active metabolites. So what I would say is, generally speaking, and again, this isn't medical advice per se, I'm just trying to make people more aware of this, but maybe a reasonable approach would be you go to the scene of a patient that kind of looks like an opioid overdose, and you do the typical things you do for opioid overdose. You open the airway, you manage the airway, you maybe get vascular access, you administer appropriate naloxone therapy, appropriate aliquots or doses of naloxone while managing the airway and breathing, circulatory status, and you check the blood sugar and deal with that if there is a blood sugar anomaly. And with xylazine, the patient's not really going to respond. You're not you're going to have all the xylazine side effects, and so you'll give the naloxone. You might give multiple doses of naloxone, and the patient still remains hypotensive and bradycardic with severely depressed mental status. And in that situation, that should be your clue. That should be a clue that, oh, we might be dealing with an adulterant like xylazine, and at that point, naloxone is just not really going to help this patient, and now we're going to need to look at definitive airway management, fluid therapy, hemodynamic support with vasopressors if needed, and then transport that patient to a hospital that has critical care facilities that can manage this patient, and then hopefully over a period of several hours to days, that patient can metabolize and clear the xylazine, and we can get them through that crisis. So that's just kind of a general rundown of xylazine, the history of xylazine, the chemical structure of xylazine, and the basic pharmacokinetics and pharmacodynamics of xylazine, and then the basic clinical toxicology of xylazine and how we can begin to think about it and approach it. And unfortunately, it is looking like it may become the dominant adulterant in the various opioids that people are using and abusing illicitly. In the illicit, obviously, if it's not illicit and there's quality control and all that, that's a different story. But I'm talking about stuff that's illicitly coming in, where there isn't any quality control going on. You can pretty much anticipate that you're probably going to begin seeing a lot of this occurring, and you want to make sure that you are able to adjust your treatment paradigms accordingly, because this does not fall under the typical paradigm of a more traditional opioid toxicity. All right, everyone, hopefully you found this video helpful. Hopefully you found it informative, and I hope you all stay safe. Have a good time, have fun doing whatever you may be doing, and I'll see you in the next video. Thank you so much.